Hello, everyone. Thank you for joining us. We're just going to give a few more minutes to have everyone join us, and then we'll get started at about 4:05. Hi, everyone. If you're just recently joining, we're just giving a few more minutes so that everyone can join and get settled, make sure that there's no tech issues, and then we'll get started at 5 after. Okay, I see a few more people still joining this. So again, we're going to be starting in about 2 minutes so that everyone has a chance to settle in. Perfect. So in the interest of time, I'll get started. So welcome everyone, and thank you for joining today's session on advancements in care for early stage breast cancer patients. My name is Bakun Adebembo, and I'm the Manager of Operations with the Canadian Breast Cancer Network. So before we get started, I'd like to cover a few housekeeping items. So this session is being recorded and it will be available from our website if you need to access it. And once the link is available, I'll send an email to let you know where to access the link, and it'll also be shared in our CBC Unconnected newsletter. There, you'll also find previously recorded webinars that address a variety of breast cancer-related topics. I'd like to extend our sincere appreciation to our sponsors for this session today, who have provided support through unrestricted educational grants. So Novartis is our gold level sponsor, AstraZeneca and Gilead are our silver level sponsors, and Seagen, Merck, and Roche are our bronze level sponsors. The format of this session will be a presentation by our expert speaker, followed by a question and answer period. So please feel free to submit your questions throughout the session using the Q&A function that you should be able to find at the bottom of your screen. I'd now like to welcome our host for this session, Kathy Amandaleo, who is the chair of the board of the Canadian Breast Cancer Network. As someone who has had an early stage breast cancer diagnosis, Kathy understands the importance of research and treatment that can help reduce the risk of recurrence. Kathy?
Thank you, Bakun. Welcome again, everyone, and thank you, audience, for joining us today. I am pleased to welcome and introduce our expert speaker, Dr. Sandeep Sehdev. Dr. Sehdev is medical oncologist and lead of the breast disease site group at the Ottawa Hospital Cancer Center. He was the past director of the Cancer Advocacy Coalition of Canada and co-founder of the Physician Alliance for Cancer Care and Treatment. He is a scientific advisor for us at CBC and past lead for continuing education for the community oncologist of Metropolitan Toronto. We are incredibly appreciative of all the time that Dr. Sehdev offers to the patient community by joining us today. So Dr. Sehdev, great to see you again, and thank you for being here.
Thank you. So I'll try to share my screen here, see if it works again. Thank you also for making time for all of you at this time before Labor Day. I kind of forgot how close we are to the school season starting, and I reflected back on how fun this is with those of you with young kids. I think we're all stocking up on our Laurentian colored pencils and our Buffalo markers. I know I did. So thank you again for joining us. So our discussion today will be about early breast cancer, which is not metastatic disease, but it's the early stage, which most of our patients we see in our practice actually have early stages of breast cancer, where the goal is to remove and cure the disease. But things have been evolving in this space continually now for decades, and even in the last 1 year. And I hope to kind of share with you an overview of how we approach this breast cancer and what's new in this area. So that's me again. My interest has always been in advocacy and education, and also trying to get the newest treatments to Canadians as soon as possible. So our objectives, again, to inform the background of what has brought us to where we are today, to review our current and new approaches, and maybe touch on future trends. So what's the scope of the problem? Breast cancer has a unique level of awareness in the community of women in Canada because it's quite common. Almost 1 woman in 8 will get breast cancer in their lifetime, and often celebrities have had breast cancer. There's fundraisers and runs. There's a high level of awareness, but the results for our treatments for breast cancer are in fact better than most other cancers we see. The top kind of graph illustrates that the incidence, the risk of getting breast cancer, has been pretty stable now for many years. But on the bottom graph, the dashed line shows that the mortality has been going down. We've had better and better treatments, early detection, and better adjuvant therapies. Adjuvant therapies mean treatments we give after surgery or sometimes just before to help prevent the cancer spreading in the future. So in terms of prevalence for all women with cancers, breast is a big chunk of them. And the reason prevalence means how many are perhaps living with breast cancer is because they can live with their cancer for many, many years. We'll touch back on that again later. So when we look at early stages of breast cancer from the clinician lens, we're first looking at, well, what type of cancer is it? On the bottom right, and hopefully you can see my arrows, there are rarer types we won't be talking about today, but the common garden variety of breast cancers either start in the ducts. The ducts are what carry the milk from the glands to the nipple, which is most breast cancers, or lobular. The lobular breast cancers begin in the lobules that make the milk, and they have actually a very similar prognosis, somewhat similar approach to treatment, but maybe a little bit of a different way they can recur later. We won't be talking about the precancerous stages. That's where the cancer cells perhaps are piling up in the ducts, called DCIS, but not yet invasive or not yet into the breast tissue. So, we categorize breast cancers mostly by their expression, their hormonal characteristics, and their HER2. We all know about estrogen on the top left, progesterone on the middle. Those are female hormones. And normal breast tissue is sensitive to effects of female hormones because it has receptors. Receptors are stained in brown in these slides for the microscope. And if those receptors are there, it's a sign the cells resemble regular breast cells. They often have a better prognosis. And the most important treatments are tailored towards blocking estrogen that sometimes can feed these cells. HER2 was discovered in the 90s, and we have treatments for HER2, a different kind of protein on the cells that define what used to be an aggressive kind, and now we have such good treatments for it that now those patients do very, very well. But the presence or absence of these three features really helps us define the buckets. What gets confusing on the right side is if you do these fancy RNA plots where, for example, every row horizontally is an individual cancer, and every column is a pattern of genes that are turned on or turned off. Off would be the green and red would be the on. You can see that sometimes it's not so simple. And ones that we think are estrogen positive may not actually have that genetic behavior. Ones we think that are estrogen negative may still be modulated by estrogen pathways. So that's kind of how things are getting more sophisticated nowadays. This just shows here, if you see the row in red, that about 40% of breast cancers are called luminal A, or they're strongly estrogen driven. Luminal B are estrogen positive, but less so usually. About 10 or 15% are this HER2 kind, where there's too much of this HER2 protein that can drive cell growth and proliferation and spread. And the rest of them are put in this bucket called triple negative, where they're not ER positive or PR positive or HER2 positive. So by default, we call them triple negative. And really, it's a bit of a kitchen sink, but we're left with treatments that don't involve HER2, don't involve estrogen, and they're kind of bucketed together. It does get a bit more complicated. As I mentioned, sometimes the ones that are HER2 positive also can express estrogen receptors. In general, the triple negative are high grade, like uglier cells. They have a poorer prognosis, and they respond better to chemotherapy. And those that are more estrogen driven, like luminal A types, are kind of the opposite. But you can see there's a bit of a mishmash in between. Most of the breast cancer cells, the luminal ones, start in the cells that line the breast ducts, or these light blue cells. And the more aggressive ones that are triple negative are often what are called basal cells. That are kind of they line the muscular layer that squeezes the ducts. So we'll be talking about these all today, but focusing initially on the most common bucket, which are the estrogen-driven types of breast cancer, which make up most of them. There are some new buckets. One is called HER2 low, and you see at the bottom left. That's where there is some HER2 on the cells, but not enough to make it the key driver that makes the cancer tick, that requires HER2 targeting. So that's kind of the types of breast cancer. What about the stages? Well, stages get a bit confusing too. We have the anatomic stages. The anatomic stages are based on what's called the TNM staging. How big is the tumor? That's the T. How many lymph nodes are involved? That's the N. And are or are there not any metastases? And that's the M. So tumors less than 2 centimeters or 2 centimeters are called T1. 2 to 5 is T2. T3 is bigger than 5. For the lymph nodes, the best is to have none involved. If there's 1 to 3, it's called N1. If there's 4 or more, it's N2, and 10 or more, it's N3. And M1 means there are distant metastases to other organs. There's some examples here, but brain, bones, lung, and liver are the most common places the cancer can go to. The trick is now, when patients read their charts, they see the computer may quote a different stage. That's because the pathologic stage, what's called the AJCC8 system, corrects the stage for the biology. So it looks at the TNM, the bigger the tumor, the worse, the more nodes, the worse, but then it budges the stage based on the biology. If it's estrogen driven, it budges it to a lower stage, for example. So it can be a bit confusing when patients look at these two. Bottom line is, we establish stages So we can all talk the same languages and we know what we're up against. Stage 1 generally have a better prognosis, they're caught earlier. Stage 4, more aggressive. Most patients are never cured. And in between, all stages 1 to 3 are called early breast cancer, but the more cancer, the more aggressive, the higher the risk of recurrence. I'll be showing lots of these kinds of graphs today where you see a curve like this. And the curve basically explains how people do. Usually on the horizontal, you see a time, and on the vertical, you see how people are doing. So for stage 1, if you look out even years out, the majority of patients are still alive. Whereas for stage 3, about half of them have passed away of recurrent disease. And for stage 4, most have passed away. One thing to remember, for the common estrogen-positive kind of breast cancer, even though we talk about the 5-year survival, the 10-year survival, the cancer can come back much later. It's a slower kind of cancer. Some of you may remember the journey of Olivia Newton-John, famous actress in Greece, country music singer. Most of my class had crushes on her in high school. When I was in university, she had a stage 1 breast cancer, and it came back in her bones, I believe, 25 years later. It only can spread if it has spread before the operation and left invisible seeds that manifest later. And she passed away last year, I think after a 6 or 7 year journey with the stage 4 disease. On the top left, you can see the curve, that if you look at long-term data, even when there's nothing in the lymph nodes, 20 years later, about 22% of patients have had spread to other parts of their body. And if they have a lot of lymph nodes involved, more than half of them do. So it's not just a 5-year point where we can ring a bell and say we're cured. It can occur later. For the estrogen receptor positive kind, there's a lump of patients that recur in the first 5 years, and there's a trickle that can recur even many years afterwards. And the trickle actually adds up to the same number of people as the first 5. So there's a bulge in the first 5, and then there's a trickle afterwards. So we have to think of it like a condition we have to be aware of and think in terms of long-term prevention. There's a new kind of scanner called a PET scan. It's not that new, I guess. It's about 20 years old now, but newly available and funded in Ontario for higher stages of breast cancer. Basically, it's a more sensitive scan. It's not actually a CT. It has a CT built into it, but the PET scan basically glows brightly because it shows where sugar is being eaten and metabolized more quickly. Cancer cells grow faster. They eat nutrients faster, oxygen, sugar. So they glow almost like a lighthouse in the fog if cancer is in the body. So if you see a funny spot, you're not sure if it's cancer. If it glows bright, it helps to confirm that it is cancer. It can be inaccurate. It can be positive for other things like inflammation or infection sometimes. But for higher risk breast cancers like stage 3, we now do it routinely just to make sure in the beginning that the cancer has not already traveled that we can see. Patients often ask me, well, if the scans are negative, why do I need drugs? If the scan shows something, it's called stage 4 and it's too late to cure. And we think of gentle treatments that can be effective for years, but we change our approach. If the scans are negative, there's still a chance that there's invisible cells in the body, and that's where it's even more important to have medicines that can tip the odds of cure in our favor. Something new too, I call them blood biopsies or circulating tumor DNA. Many women are reading about this online. They're asking for it. They're paying a lot of money to get it done in the States, sometimes $2,000 a blood test. It's a test that's not quite there yet. It's not recommended by routine international guidelines, but it is being researched actively. So in the circulation, tumors do break down and they release some of their cells and some of their DNA, that's the squiggles here, into the bloodstream. And sophisticated tests now can pick up either the cells, called circulating tumor cells, or the DNA, and sometimes give us a clue that that person may have a higher risk of cancer coming back later. It may give us a better prognosis. It may tell us how the treatment's doing, but it's not quite there yet because it can miss patients who are destined to have it come back. And the people where they have some of this in their blood, maybe they're exactly the people where the adjuvant preventive therapies are actually curing them. So it's not enough to say that, we should change our treatment yet. So again, what are the goals in early breast cancer? Is to make sure the cancer is cured, to tip the odds in our favor. We're talking mostly about adjuvant treatments today, preventive treatments, insurance therapies to help kill any rogue cells that could be in the body, and they're tailored to how high the risk is in that patient. Neoadjuvant, neo means before. That's where we give the medicines before surgery in some patients to help things go better. What are the advancements? There's lots of advancements in breast cancer, earlier detection, MRI, for example, radiation dosing and schedules. Radiation used to be 25 or 30 shots. It's now often just 15, sometimes 5. But today we'll be talking in our discussion mostly about adjuvant drugs. That's my expertise, and talking about these drugs by the bucket, what type of disease bucket the patient's in. We won't be talking about individual patient examples, drug funding issues, or the important issues of how we monitor people afterwards. So what are the drugs we have? What are the treatments we have? We know we have surgery. Surgery is required to cure breast cancer. It may not be one day. The drugs are coming along so quickly. One day we may not have to. We already know we don't always have to take nodes out in some patients, but that's kind of early. Radiation or X-ray beams that zap the area, usually after surgery, to help prevent any leftover coming back in the area. Systemic therapy just means drugs, and there's all different kinds. And immunotherapy is something new that we particularly use now in triple-negative breast cancer. It was first discovered about a decade ago in melanoma. It's used in many cancers now. So how do we decide? How do we decide who needs treatment? We want to use treatment where there's the most benefit, where it depends on the risk. And where we give drug treatments, on average, about 1 life in 3 or 1 life in 4 that would have died of recurrence in the body can be saved. It's a massive benefit. Sometimes the actual amount might be 5%, 10% better odds of surviving. But overall, the benefit is actually better than most medicines we give in health. My blood pressure and cholesterol pills might lower my chance of stroke or heart attack by 1 person out of 8 for taking them my whole life. And our treatments save 1/3 of the lives for only usually a short duration. What type of treatment depends on the bucket of cancer, the risk, and we only give treatments if the benefits are proven. Right now, people are asking, what about this I read about? What about that? We have to have proof they actually work before we can use them correctly. Most of these treatments are discovered in stage 4 disease, the newer ones, and when they work like gangbusters, they get moved up and studied in the early setting to see if they may even further improve the chance of long-term cure. We do have something called the NHS Predict. It's the online model where we or patients can punch in their cancer features, and it tells you on the right, based upon their database of thousands of patients, of the patients who had that kind of cancer and that kind of treatment, how did they do? So let's say this example of this woman, she's 65 years old. With her kind of cancer, if she never had cancer, people her age, 87% will be alive in 10 years. If she only had surgery, it was 70%. And with the preventative treatments recommended, it becomes 80%. And this can help women decide what the value of treatment is and whether it should be given. The caveat is this tells you what's the chance of being alive. And I don't want patients just to be alive. I want them to be alive and well. Some of these patients who are quote unquote alive are living with cancer that is spread. So I want even better than that. I don't want them just to be alive. Let's first talk about the commonest bucket. That's the estrogen sensitive bucket. How do they work? What treatments do we use? The oldest one is called tamoxifen. I think it was a Dr. Bateson many, many years ago discovered that I think it was urine from nuns that had a certain kind of estrogen could be used to treat people with breast cancer, and they had responses to it. And they kind of picked up on this hormone sensitivity. So how does estrogen work? Estrogen binds to a receptor on the outside of cells in the breast. It activates that receptor. Together, the two go down to the nucleus of the cell, where they turn on genes that cause growth of cells and eventually spread of cancer cells. Tamoxifen is about a 50-year-old drug that is sort of like a master key imitating estrogen, basically jams the keyhole, breaks off the key. It binds and blocks that receptor. And when it blocks that receptor, estrogen can no longer turn it on. So any cells that might be sensitive to estrogen that could be lingering might wither and die. And that's how tamoxifen works. Aromatase inhibitors are about 25 years old now. Instead of blocking estrogen, they take it away. They only work after menopause. After menopause, the ovaries are turned off. They don't make estrogen, but the body makes estrogen through a bit of a back door where it converts the bit of male hormone women have their whole life into a bit of estrogen. And these pills kind of shut the back door. And by dramatically lowering the amount of estrogen, it also prevents cancer cell growth. So what's the data? Well, we have long-term data now from decades of observation showing that if people have the estrogen-sensitive kind, if they don't take any medicines, there's a high risk of recurrence. If they take tamoxifen, that risk is dramatically less, 40% down to about 25%. So this has been shown to save lives. The hormonal therapy, it's not really a hormone, it's an anti-estrogen, but that therapy is probably the most important treatment for prevention of recurrence in this kind of breast cancer. So what about the aromatase inhibitors? Well, if patients get aromatase inhibitors, they do even better. In the studies where half got tamoxifen and half got aromatase inhibitors, there was another 3 or 4% less chance of recurrence with those drugs. But the result is just as good if people take them for half of the duration or take it for the whole time. So either we use aromatase inhibitors for the whole 5, 6, 7 years, or we give tamoxifen for the first half and the AI for the second half. And the benefits of doing half and half are less cumulative side effects. Whatever cells might survive one, we hit with the other, and maybe some safety issues. There are some good side effects of one that can counteract those of the other. So some people may have a reason not to take one. For example, one might cause side effects that's not a good fit for that patient. What are the side effects? Well, I always tell women when you read side effect sheets, remember that Advil, penicillin, aspirin have long sheets as well. Many of the side effects listed on sheets are probably wrong. When they do studies for prevention, where half the people get a fake pill and half get the real tamoxifen, many things listed happen just as often with the fake one. So they're things that happen by coincidence. They have to put on the sheets whatever happens to a woman, even if it's not from the pill, and that's why they can be confusing. So the things that we discuss, mostly hot flashes. We recommend avoiding soy extract. It has estrogen properties. Soy is okay, tofu is okay. There are antidotes for hot flashes if they're difficult. They often get better after many months. Sometimes it can cause a vaginal discharge because the vagina thinks it's like estrogen, makes it moist. That could be a good thing if it's naturally dry after menopause. It can cause a bit of dryness. There's about a 1% chance of blood clots, exactly the same as estrogen pills and birth control pills. So very low, but something we always watch for. And if you take it, especially for 5 years or more, 1 in 500 women might get uterine cancer because the uterus thinks it's estrogen. And it doesn't require regular ultrasounds or tests, just awareness. If someone has spotting, we always check. In 34 years, I've only seen one case of that, thankfully. So the chance of it saving life and preventing breast cancer is much greater than any of these things. And it's really important we keep fear in check when we educate women. There are some beneficial side effects, less heart disease, lower cholesterol. It actually strengthens bones in postmenopausal women. What about the aromatase inhibitors? Lots of things listed. They often list higher cholesterol. But in studies, again, where half had tamoxifen and half had the aromatase inhibitors, what they actually thought was that the tamoxifen lowered the cholesterol and made the AI look worse. And the AI actually didn't actually change the cholesterol. So it may not really be as much of an issue as we thought. What we talk about, again, hot flashes, they're less of a problem than tamoxifen. Vaginal dryness can be a problem with less estrogen. We try to avoid estrogen creams. It gets into blood a little bit. After menopause, the bone density can go down, so we watch for osteoporosis. We recommend vitamin D, calcium, and exercise to avoid alcohol and smoking. The risk is quite small, and we monitor the bone strength. And the most common thing is achiness. Patients often feel like the Tin Man in Wizard of Oz. When they're laying in bed or chair and they get up, they first feel stiff and creaky until they get walking around. Usually it's better with Tylenol, exercise, warming up. But sometimes if it's difficult, we stop the medicine, it goes away in a few weeks, and we often succeed by just switching to a different brand. So it's something we're pretty good at managing. For young women who are before menopause, we only can use AIs if they're in menopause. And sometimes we put them into menopause deliberately because going into menopause means the estrogen levels are even lower and the chance of cure is better. How do we do that? There's drugs. There's one called gaserolin. We know we can give it every 3 months now by an injection, and we do that for 3 to 5 years. In high-risk patients, they might just take the ovaries out. It's day surgery. It's done through a telescope, just like having your tubes tied. So it's not too difficult, but generally we give medications. So who needs treatment like that? Usually younger women where they have a higher risk feature, where we're really worried about the risk of recurrence. On the left, you can see for younger women who are still having periods, if we turn their periods off, the risk of recurrence goes from 41% to 29%. So it really can help to further prevent recurrence of their cancer. Side effects, basically the side effects of inducing menopause, and having menopause hit abruptly can be a bit miserable. So what about how long do we give anti-estrogens? If we're just giving tamoxifen, there are studies now that show that 10 years is better than 5. It's a long undertaking, but the recurrence rates are lower, 4% lower. The risk of dying is a bit lower. So in a higher risk young women, we sometimes will give tamoxifen for longer. What about aromatase inhibitors? If someone has finished 5 years of tamoxifen and we add an AI for 5 more years, it also helps lower the risk. What about if someone just had an AI for 5 years? We know that adding a bit more, like 2 more years, further improves the risk. The risk goes down to 77% of what it would have been when you add all these trials together. So in many women, we'll actually go to 7 years. We now know it doesn't really help to go longer to 10. 7 is probably just as good. And in low-risk patients, 5 is enough. So we customize that discussion with our patients. So that's kind of, the overview. The point to emphasize is the anti-estrogens are very important. One of the most common reasons for breast cancer recurrence can be non-compliance. Many studies show that 35 to 40% of women stop taking their anti-estrogens. They read misinformation, they get scared of fake news, they get frustrated by the side effects, and they stop. So encouragement, attention to detail, helping them with side effects is really important. What about chemotherapy? Chemotherapy also helps women with estrogen receptor positive breast cancer patients, but it's not quite as important. So we've known since the 1970s that after early breast cancer, this is in patients where it's in their lymph glands, so stage 2, giving chemotherapy improves the outcome. The chance of remaining cancer-free is higher. This old chemo CMF is sometimes still used. So we've known that for a long time. Currently, we have different regimens we give. We use different drugs now. We use usually a combination of anthracyclines that are derived from chemicals found originally in fungi, and taxanes. Taxanes are a chemo drug that originally were found in the yew tree. And often we get half and half. And for lower risk patients, we'll just give 4 treatments of a regimen like TC from the yew tree and not require the anthracyclines. The anthracyclines have a small, rare risk of permanent heart damage or of maybe 1 in 200 additional risk of leukemia in older life. That's one reason we might want to avoid it in some patients. We now know that we don't have to give chemo to everyone. We used to give chemo to most of our patients for tumors bigger than 1 centimeter because it would prevent incurable spread. Now we have tests called genomics. Oncotype DX is the most commonly used test. There are other ones, a MammaPrint, for example, where we look at the genes in the cancer, not genes from mom or dad like Angelina Jolie, but genes that go wrong in cancer, and look at the genetic makeup. And if the genetic makeup is not aggressive and the score is good, then whether or not chemo is given, the results are exactly the same. So you can see 2 curves here, red and black, and they're exactly the same. So if patients have their tumor sent to California for this $4,000 test, it's paid by every province now. They can be told that their score is low and they don't need chemotherapy. Sometimes they want chemo. Their family died of cancer, and we can tell them, look, even if patients had chemo, the result was the same. It could come back anyways, but chemo won't make it better. Now, more recently, we've known that even if the cancer is in the lymph nodes, 1, 2, or 3 lymph nodes, if the score is good after menopause, chemo is not necessary. So one of the biggest advances in the estrogen-positive breast cancer has been cutting back on treatment and avoiding chemotherapy. In premenopausal women, where the cancer may be more aggressive, chemo does still make a difference. So that test, if it's in the lymph nodes, generally is not used in younger women. Side effects of chemotherapy, the list is long, but in general, patients take it well. Age itself is not a reason not to have preventive chemo if we think someone's health allows. If they have another disease that's going to shorten their lifespan a lot, it may not be worthwhile. But the common side effects are in blue. Hair loss is pretty universal. The old CMF recipe caused hair loss in only 20%, but it's otherwise more miserable. Canker sores, weight gain, diarrhea, for example. The chemos often cause some mild nausea, but almost never vomiting anymore. We have tremendous medicines that prevent vomiting. Taste buds go flat. People can gain weight if they eat more sugar or fat, for example, if we watch their diet. Fatigue probably is the most frustrating. It can vary, down for a week, good for 2, or you can be tired for several months of the treatment. And sometimes there's a risk of bacterial infection, not so much viruses like COVID or flu, but when the white blood cells go low, bacteria from within the body can cause blood infection that can be very dangerous. That risk for modern treatments is usually only around 5%. I've never had a patient die of that. I've been lucky in decades. And rarely, again, some of the recipes can cause those long-term side effects we spoke about. The taxanes can cause numbness and tingling, nerve inflammation, bone aches for a few days. So it is crappy. It can be miserable, but we can get through it. And most patients, even when they're older, can tolerate standard doses. So the other thing advance we've made in the last decade or so is giving the chemo recipes every 2 weeks instead of every 3 has been found to improve the cure rates. You can see the recurrence rate drops by another 3 or 4% because we give the chemo closer together. There's less time for cancer cells to grow back between the cycles. So we call that dose-dense chemotherapy. We have to use a white blood cell booster with the chemo to help the white cells recover in 2 weeks so we can give the chemo closer together. And this is another common strategy. You may notice that many of these curves show 4% better here, 4% better there, but all of these changes have been incremental and additive over the decades. So we're getting results that are better and better and better. There are new treatments called CDK4/6 inhibitors. These are pills. What is CDK4/6? CDK are checkpoint roadblocks in cell division. Many of you may remember your high school biology, something called mitosis, where one cell gets the signal to divide into 2, and 2 become 4, and 4 become 8. There are checkpoints that tell the cell to divide, and the most important one in breast cancer is called CDK4. And these pills help turn off that clock timer that tells the cells to divide. They've been the biggest advance in estrogen-positive breast cancer in the last 20 years, and they're used routinely now for patients with stage 4 to dramatically improve how they do and how long they live. So there's data now giving them for prevention. So the first one was called abemaciclib. The brand name is Verzenio. And they took people with high-risk breast cancer. They had to have at least 4 lymph nodes with cancer or 1 to 3 lymph nodes with some other bad feature, ugly cells, big breast tumor, or very fast cell speed. And they got either standard hormonal therapy or they got hormonal therapy with this extra pill for 2 additional years. And there was another drop by about 6% less in the chance of developing recurrent disease. So this is already standard treatment now. And we do this routinely across the world in those high-risk patients. Side effects, diarrhea, it usually lasts for only a few weeks and gets much better. Fatigue, it can cause hair loss or hair thinning is more likely. Rarely lung inflammation. It can also lower the white blood, but the risk of infection is only around 2%. So generally very manageable. And we eventually only have to see people every 3 months or so when they're on that additional treatment. The main problem is it's very expensive. It's over $10,000 a month. Once the government negotiates prices and it's government funded, it should be much less expensive. Right now, it's available compassionately. Ribociclib is another very similar drug. We already use it in stage 4. It's hard on the tail of abemaciclib. And this study called Natalie looked at using it in similar patients, but also included lower risk patients who, for example, did not have any cancer in their lymph nodes. It did not include the very best patients with low risk, but it included the average patients, not just the bad ones. And the data is early, it's not quite mature enough yet, but the results are looking very similar. This is now being offered to patients now across Canada in many centers on a research study called the WIDER trial, in case patients don't qualify for the abemaciclib. And this is a 3-year undertaking. So that's what we're doing so far. In Germany, they picked up this new approach that they're studying and doing routinely, looking at giving hormonal therapy before the operation. It's not routine now. We sometimes do this in older patients who don't want surgery, or they have Alzheimer's, a lot of serious health problems. They would not be able to have a general anesthetic and a mastectomy, and we give hormones to shrink their early breast cancer to make it operable or just to control it during their lifetime. But in Germany, what they do is they first actually give a hormonal therapy for a few weeks, for about 3 weeks. And then they repeat the biopsy and they do a test called the Ki-67 to look at, is the speed of cancer cell growth gone down? If it's responded really well to hormone therapy, they're considered low risk and they don't get chemotherapy. If it's high risk and there's no benefit, they move on to chemotherapy. If it's in between, they look at tests like oncotype, gene scores to help them to decide. And that is being studied now to see if that may be a better way to go to better stratify or decide who needs what. So take a breath there. There's been a big discussion about the estrogen positive breast cancer patients, emphasizing the importance of the preventive hormonal therapies, how we use chemotherapy in patients who need it, either 4 nodes or more, or bad genomics or other bad features, how chemotherapy goes, and how we can use modern targeted pills to help reduce the risk in those patients. So let's move on now. The HER2 positive type is one of the buckets I mentioned before. 15 to 20% of patients have this type. HER2, again, is a protein on the outside of breast cells. Normally it is there, and about 20% have too many of them. And they activate these signals like a gas pedal down to the nucleus to say grow, proliferate, divide, and spread. So treatments to block that, the first one was the trastuzumab, the brand name was Herceptin, came out in about 2001, the biggest advance in breast cancer really in decades now. Trastuzumab is drawn here as this yellow Y-shaped antibody, and the antibody basically attaches to that signal to turn the signal off. So by attaching to it, it turns the signal off, and also it is an antibody, an immune system protein developed by engineers, and it basically attracts these big immune cells to come over here and kill this cell. And that's kind of how it works. So how do we give it? In HER2 positive patients, we give it after surgery with chemo. So we use very similar chemo recipes we mentioned before, but we add in the H, which is the trastuzumab. It's H because the brand name used to be Herceptin. We have other brands now, other competitors that are called biosimilars that we use more commonly. But that goes with the chemo, but it goes on for 18 doses, usually over 1 year. 2 years is not better than 1, and that's why we do the 1 year. Side effects, usually very well tolerated. Sometimes when they give the intravenous, it can cause chills or reactions, and rarely it can cause temporary weakening of the heart muscle. So if we stop it, it generally goes away and we can resume. And we do heart ultrasounds every 3 months. So that's that history many of you may know. And this just looks back at the data since it was discovered, how the recurrence rate for what used to be the worst kind of breast cancer has now improved dramatically. So 32% to 22%, the chance of dying has gone down substantially in these patients because of this preventive treatment. Recent advances, well, we've actually found that we can give it with less chemo. It's a partner with chemo. It doesn't work by itself. But if you have a small breast cancer, less than 3 centimeters, not in the lymph nodes, we can give that one drug from the bark of the yew tree, paclitaxel, with the trastuzumab for basically 12 weeks, and then finish the rest of the year. And the results seem to be just as good. 94% are doing well down the road. The other thing is that some people don't need 12 months. In all the studies where half the patients got 6 months and half got 12, they all showed maybe a slightly higher chance of recurrence with 6 months versus 12, but they were felt to be almost equivalent. So if someone has not high risk, if they don't have it in their lymph nodes, it wasn't ugly, we often are offering 6 months then stopping. We also give it before surgery. Why would we do that? So we talked a bit about that before. In the HER2 positive patients, this has now become a very common approach. So one reason we give it before is cosmesis. If we can shrink a big tumor, we can go from mastectomy to lumpectomy. We can also start treatment early if there's OR delays like we had during COVID. The other important reason is many patients get a home run. When they operate, they don't see any cancer left, and that tells us the prognosis is excellent. Nice to have that added information. And it also helps to guide the next steps. If we do operate and there is leftover, we know that instead of finishing the rest of the year with trastuzumab, we can change to a different medicine that can save lives and better improve the prognosis. So just by adding the trastuzumab compared to chemo alone in these patients, the chance of getting the home run where there's no cancer left at surgery is about 30% to 50%. That is phenomenal. If there's a bit left, it doesn't mean they're all going to have recurrence. It just means the risk is a bit higher. So now we do this in everybody that has stage 2 disease or worse. In other words, at least 2 centimeters in size or in any of their lymph nodes. The complete responses, if they have a complete response with nothing left, I call it the home run. If you look from that point forward, their prognosis is much better than if they don't. If they don't have a complete response, the risk of recurrence is higher. Pertuzumab is another antibody that attaches to HER2, but it attaches to HER2 from another side, basically. And it combined with trastuzumab, it works even better. In metastatic disease, patients live much longer if we give the two together. So in one study, when they gave the two together with chemotherapy, and not just the one, there was a higher chance of a home run. The complete response rate was very high. Unfortunately, it's not funded in most of Canada. It's funded in Quebec and most other Western countries. It's because of the cost. Most doctors would like to give it. It improves that chance of home run by about 15%. But Canada, unique amongst most modern countries, has decided not to pay for that. What else is new? If we find that we give treatment before and there's leftover, they did a study where people either finished the rest of the year of the trastuzumab or they switched to a cousin. And the cousin was called trastuzumab emtansine. It's trastuzumab, the antibody, with a small chemo molecule riding piggyback. And the advantage is the chemo only goes to where the HER2 is, the cell eats it in, and it doesn't really damage the whole body. So it's a very effective kind of treatment. This is the idea. Here's the trastuzumab, here's the chemo riding piggyback. And in the patients that had stubborn disease, where we were concerned that they had leftover, if we switched the rest of the year to this drug, the results were about 11% better, with less chance of recurring again. So that is also our routine standard of care now. And by giving the treatment before, seeing how much is left, we can custom tailor what we do after to maximize the chance of cure. There's a new drug in a similar vein called trastuzumab deruxtecan. It's used now in stage 4 disease. It's a big breakthrough. It has another chemo riding piggyback, but more chemo riding piggyback. And it's a kind of a chemo class we've used in bowel cancer before. So a similar way it works, it binds to HER2, the cell eats it inside, it releases the chemo inside and in the neighborhood. And that is being studied now also in earlier stages of breast cancer. After people finish the 1 year of HER2, there's a pill called neratinib that you can take for an extra 1 year. It blocks the HER2 from the inside of the cell by kind of log jamming that keyhole that HER2 goes in through. 6 pills a day for an additional 1 year, very expensive, not paid for in Canada by governments, but we can get it free from the manufacturer. And this just shows that in patients, especially with the hormone-positive HER2 patients, especially if it's in their lymph nodes, it may further improve the chance of the cancer coming back by another 5 or 10%. So in higher-risk patients, particularly if there was leftover at surgery, estrogen positive, we sometimes will use this as well for an extra 1 year. So those are the major advances in the HER2, giving the treatment before for most cases. If they're very small tumors, we operate and give a milder chemo backbone afterwards. And if they have leftover, giving custom tailored approaches to further tip the odds in our favor. So the last bucket we haven't talked about is triple negative breast cancer. Triple negative cancer has the worst prognosis. So if you look out from the beginning, how do they live from the time of diagnosis with stage 4 disease? They do very poorly. It's the most aggressive kind. And the only treatment we used to have was chemo. We can't use hormones. We can't use HER2. In the old days, we would operate and then give chemo preventatively. Standard chemo recipes we discussed before. There's a kind of chemo called platinum that may add effectiveness in this kind of breast cancer. Now we're giving the chemo again before surgery more often, and in some patients giving immunotherapy and other drugs. Why do we do this here? Again, if we shrink it, we can get less surgery done. We give immunotherapy often with chemo before the operation. When we operate, if there's nothing left, we know they have a much better prognosis. If they do have something left, we know that giving additional chemo with a pill chemo that's pretty mild, called capecitabine, can further improve the outcome. And that's why also for stage 2, 2 centimeters or bigger, or in the lymph gland, we're trying to give treatments before the surgery for these 3 reasons. This just shows again that adding this additional chemo called platinum can improve the chance of the disease recurring and can improve the overall survival, the chance of life or death in many patients. It does add more side effects, mostly numbness and tingling, and it can add more fatigue. So it is a bit of a hassle, but it does improve the outcome. I mentioned that if we operate and there's any cancer left, and we give this pill chemo, the pill chemotherapy can further improve the chance of remaining free of cancer by an additional 14%. So that's something we do afterwards, an old chemo we've had for a long time. What's new in triple negative? There's something, remember we talked about the drugs in HER2, like TDM1. There's an antibody with chemo writing piggyback on it. And this antibody doesn't attach to HER2, it attaches to a protein called TROP2. And 90% of triple negative breast cancer patients have this protein on it. In this case, we're not so much trying to turn off TROP2, we're using TROP2 as a door to sneak this chemo in. And this chemo then gets into these cells to help kill them. And right now, there are studies going on now of drugs like that. There's a couple I mentioned here, where if people have chemo and there is leftover, instead of just giving capecitabine or pills, we're giving these drugs after instead to see if they may further improve the results. And that's an active space where the clinical trials are accruing right now. We just started the patient today on one of them. Immunotherapy has been a big breakthrough also in triple negative breast cancer. It doesn't work in most breast cancers, but it does seem to help in triple negative. Immunotherapy came out first in melanoma, like I mentioned. And the best way I explain immunotherapy is what I call the cop and dog analogy. Many may remember the old movies where there's a crook in the jungle. The cop brings the dirty sock to the crook. The dog smells the sock and goes after the crook. So the 2 classes of immune therapy drugs we have are meant to take the brakes off. There are natural brakes in our immune system to stop the immune system from being overactive and attacking our healthy body parts. So there's one called ipilimumab we use in melanoma that helps take the brake off in the communication between the cop and the dog. And the ones we use in breast cancer help take the brakes off between the police dog and the crook. The crook is the cancer cell. The police dog is the T lymphocyte, the immune cell that tries to kill the cancer. And this kind of protein that we're trying to block it, take the brakes off, acts like a cloak that helps the cancer cells kind of hide. The cancer cells are body cells of ours, and our body cells have flags that say, "Don't eat me." So we try to take those flags away. In this clinical trial, patients had all that chemo we talked about before surgery, but with it, they also had this immune therapy called pembrolizumab every 3 weeks. If they did very well, if they had and this is the long-term results, if they had the immunotherapy, the chance of remaining free of cancer 3 years out was a fair bit better. 76% went up to 85%. So it does really help to prevent cancer recurrence. What are the side effects? Sometimes the immune system can attack the healthy body parts by mistake as innocent bystanders. Many medical conditions that we all know about are caused by the immune system by mistake attacking us. Underactive thyroid, colitis is a bowel disease, psoriasis is a skin disease. They all can be triggered. The most common ones is an underactive thyroid. You just take a supplement for your whole life. That's pretty easy to treat. Sometimes skin rashes. Sometimes the hormone system that makes cortisone can be turned off. That's more of a worrisome one. And in a clinical trial, of 782 patients, there were 4 deaths from hormonal crisis, from brain inflammation, liver or lung inflammation. So it's something we have to be very careful with to make sure the patient does not already have an autoimmune disease, and we monitor them very, very carefully. We know how to do this well. I'm just starting one patient from yesterday on treatment today on this. Questions we have about this treatment: do we need to give it to everybody? If their tumor is smaller, do we really need it? Do we have to give the full 1 year? It goes with the chemo and it goes on for 1 year total. How to predict who will get side effects? It has a lot to do with the microbiome of the bowel. Antibiotics can affect the germs in our intestines and make it work less effectively. Do we have better biological tests on the tumor that can help us tell where it works better so we know how to choose patients better? These are questions of active study. PARP inhibitors are relatively old, but newer in breast cancer. What is PARP? PARP is an enzyme that helps our DNA repair itself when it's damaged. So in patients who have genetic mutations called BRCA1 or BRCA2, you may know them as the Angelina Jolie gene. She inherited that from her family, and it can cause inherited breast cancer. In those patients where the BRCA1 does not work because they have a mutation, and that system cannot repair DNA damage, if we give a PARP inhibitor, a drug to block the backup DNA repair mechanism, the cells rapidly die because both of their mechanisms to repair DNA are both turned off. So PARP inhibitors work primarily in people who have those BRCA mutations. So in this study, patients who had high-risk triple-negative disease, where they had leftover after surgery, or some patients who just had the surgery first but had high-risk features, they were randomized to this pill called olaparib twice a day for 1 year, or not to have it. And the results were better. The chance of remaining free of cancer went from 79% to 87%. And these treatments are pretty well tolerated. They can cause nausea, but usually mild. They can cause tiredness and anemia. So we have to watch their blood test carefully, and sometimes some gastrointestinal side effects like nausea, diarrhea, but usually they're pretty manageable. We don't have to stop it very often for side effects. So questions here. We talked about capecitabine chemotherapy for leftover after surgery, olaparib in people that have the BRCA mutation. They're on immunotherapy maybe for the rest of the year. How do we combine them? Is one better than the other? Right now, immunotherapy tends to be a mainstay if they got treatment before, and this research is actively ongoing. So in summary of everything that I've said in the last 50 minutes or so, we now have better tools to predict how patients will do. Genomics, better types of scans to see what their stage is. We have better adjuvant treatments that are customized now by the bucket of type of breast cancer, by the stage. We have better treatments to give before the operation in the badder kinds of breast cancer, triple negative, HER2 positive, that make the long-term results even better. We have additional treatments we can layer in. What are the problems? These are all adding tremendous costs. Our healthcare costs for medicines have gone down across all of medicine because we have a lot of generics now for most medical diseases. But for cancer and rare diseases that have been going through the roof, how do we pay for these drugs that are making major advances? What about the additional side effects? Patients are frightened of side effects. They're frightened of cancer, and they find it very complicated. Talking about chemo is complicated. Talking about immunotherapy with chemo doubles the complexity. It's a lot to take in. I encourage women or men with cancer to always come to our clinic with a friend or a relative to take it all in. The Canadian Breast Cancer Network makes a fantastic book called Breast Cancer and You that I've been fortunate to be involved with that really nicely summarizes a lot of these things. I like to market for patients and circle all their features, all their tests, cross off the wrong parts to customize it for them so they can go home. But we need to have informed patients, shared decision-making, and to understand what the patient's perspective is on how important is it for that person for an additional 4% benefit for the trade-off in cost and side effects to do what really fits for that individual patient. A few miscellaneous things. What about bones? We've known that breast cancer can cause bone thinning. We don't know why. We know that chemo can thin bones, anti-estrogens can thin bones. In your bones, there are these Pac-Man cells that break down bone, and there are these kind of Bob the Builder cells called osteoclasts that build bones. They're always active. They're always establishing a proper balance. If you take up sudden weightlifting, your body will borrow bone, send the calcium through your blood to other bones where it's built up to meet your needs. In pregnant women, bone is borrowed to be sent to the baby. So tumor cells actually tip the balance, and they release chemicals that activate the Pac-Man and cause bone destruction. And anti-estrogens also can increase the risk of bone breakdown. So we've done clinical trials of bone strengthening drugs like GPs give for osteoporosis. The most common one is called zoledronic acid. My relative got this for osteoporosis through her family doctor. 15-minute injection twice a year for 2 or 3 years. Very well tolerated. People take it with vitamin D and calcium, and it actually helps to prevent bone thinning, but it also helps prevent the cancer coming back by an additional 3 or 4%. It may make the soil in the bone less fertile for cancers to take root. And it may also reduce the risk of cancer coming back in the lungs or liver and not just in the bones. So we give this now quite routinely to patients, with the exception of ones that have low-risk breast cancer, where their prognosis is already so good, we don't have to give the additional therapy. There's a pill version called Clodronate, with 2 big capsules in the morning and 2 big capsules in the evening for the same 3 years or so. And that may work just as well. So here you see if patients got this kind of treatment or did not get this kind of treatment, the risk of metastases was improved by about 3%. The risk of death was improved by about 2.5%. That may not be worth it to some women, but because it has the additional benefit of almost guaranteeing the bones won't thin, it's a very well-accepted medication. There was a trial done of one that's given as a pick in the skin by GPs. The GPs give it for osteoporosis. It's often easier to give. But this one has to go on long term. It's not just for 3 years. It also showed a dramatic reduction in the risk of bone fractures, which women get as they get older. But it also showed a slight similar reduction in the risk of cancer coming back and a slight improvement in overall survival, reduction in the chance of dying of breast cancer. The downside is the bone protection is temporary. When you stop it, the bones thin again quite rapidly. And these are not government funded because they're more expensive. The other thing we talked about a bit before was circulating tumor DNA. Remember I mentioned you have these blood biopsies where you can pick up traces of cancer in the blood. How are we going to use these? They are a sexy topic. Patients are now paying and coming with reports to show me to say, well, what do I do with this? And the problem is that even now, international guidelines don't recommend this test be done because we don't know what to do with it. If we find evidence of circulating tumor DNA, it means for sure that woman has a higher risk of it spreading later in the body, but it's not guaranteed that it will. All of our effective adjuvant treatments may be killing those cells gradually over the years. And if they don't show DNA, it doesn't mean it won't come back. There may just not be enough to pick up on our test yet. This just shows as one study from the German breast cancer group. Other studies are very similar. But after patients had their first operation, if they had circulating tumor DNA in these pink lines, the chance of their cancer recurring was much higher. The chance of remaining cancer-free was low. If they didn't have any DNA in their blood, the chance of remaining cancer-free was much higher, 80% versus here, 40, 50%. So it does help as a prognosis, but it's very high tech. Remember, the Human Genome Project took billions of dollars over 2 decades to decipher our human genome, and we're now doing fancy, sophisticated tests like this for a few $100s. One day, I think this will be the future, but we're not quite there yet. So again, we don't know where we should use it. We don't know how to interpret it. We don't know if acting upon it by giving a different drug is really helpful or not. And it can cause a lot of anxiety and cast a tremendous shadow over life. So I think we're bang on schedule for my 60 minutes there. I'd like to thank you for your attention. There's a lot to cover. This information is largely covered in the CPCN book I mentioned. I think the PDF of that book is available on their website. So I'll pass the torch back to our moderator to maybe answer any questions.
First, allow me to thank you for this amazing presentation. Very well done. It's easy to understand. And I think our audience was really well absorbed into this because of the amount of questions that have come in. And it's also nice to see how the medical community, the research, everybody who has come together to make these improvements and advancements and to understand how ER positive patients can relapse later on in years. So if we're going to go to that point, exactly, like I'd like to just dive in. I would call it the elephant in the room, oophorectomy. What is the idea around estrogen positive, going through all the treatments that you described, and then whether or not to have, and we're not talking BRCA, we're talking just straight up ER positive. What are your thoughts, or what is the thought around oophorectomy? I know it's been going back and forth over the past few decades.
So we know in women that are still having periods, if they're premenopausal and they're the estrogen sensitive type. Taking away the estrogen factory with oophorectomy, or what I call medical oophorectomy, turning off the ovaries with those drugs, does definitely improve the prognosis. The thing is, if their prognosis is very good because the cancer was small and not very risky, is it worth the additional side effects? Having a sudden menopause or menopause when you're 33 is not fun, right? So it can have a downside for quality of life. Oophorectomy means permanent, right? You have menopause symptoms, you can't go back. So if we decide to do it, we like to start with the needles, because if patients don't like it, absolutely we can stop, and it's temporary. If a woman is very young and they go through chemo, the chance of their periods coming back is very high. They have active ovaries. If a woman is 47 and they go through chemo, most of the time the periods will not come back. And adding the oophorectomy or hormone drugs probably is not going to help very much. The chemo actually puts them into menopause. So there's a bit of an age factor. The younger they are, particularly under 40, under 45, and it's a sliding scale. You also factor in how nasty is the cancer. If the cancer was nastier and they're 45, maybe we want to put them on those medicines anyways. The advantage of the medicines, it's 3 to 5 years. It's not forever. So it's often something we prefer to do. In a woman with BRCA, we do it because we want to prevent ovary cancer. Some women prefer to do that because it's one-stop shopping. They hate needles. So really the choice of which approach is up to the patient, but who we do it in really depends on their age, how bad was the cancer, and how close are they to natural menopause.
Great. Now, when we're talking about 1 to 3 lymph nodes, so that's first 1 to 3 and then more. So early stage can go to 3. What about microscopic cells in the first lymph node or first or second? Some women get just tiny microscopic. How do you see that? Where do you take that?
Yeah, so a lot of the clinical trials we look at that tell us what to do, in the old days, they would put those in with the lymph node positive patients. So you have to know, what trials are what when you're looking at them. We know now for sure that if there's microscopic, I call them dots of cancer in the lymph glands, especially just 1 or 2, the prognosis is closer to someone with 0 lymph glands than to someone with 1 lymph gland. It's actually kind of halfway in between. So I think of them more like a node negative patient, like one where it's negative in my decision making. We still do Oncotype DX, to help see what the risk is, what the genomic level, but it's actually, a better prognosis. It's not quite the same as if it is 0, but it's closer to 0 than it is to 1 full chunky node.
So I guess it would case by case, I guess.
And the other common category, the common question would be, people assume that the cancer must go through their nodes to go to the whole body, and they think if their nodes are clear, they're off the hook. The cancer does not go through the nodes to go to the body. The nodes are just one of many indicators, the size, how ugly, how fast. It's one of the telltale indicators. So if it goes to the nodes, maybe it's more aggressive, maybe it's been there longer, but it tells us the chance it also went through the blood is a bit higher.
Okay, that's very clear. So before I move on to the questions submitted, obviously these are women that are probably going through this now. I have a question for the patients that were diagnosed years and years ago, were young, and now are understanding that their recurrence could happen. Is there any consideration of what to do with patients like this that are not symptomatic, that are doing very well? Are there studies? Is there a maintenance factor that might be considered? Can you speak a little bit to that? Because there are a lot of women in that bucket.
Yes, it's a tremendous cause of anxiety, isn't it? Because, for lungs, the symptoms are coughing and breathing. For the liver, it's belly aches. For the bones, it's achiness, like back pain. Everyone's going to get a cough, backache, a belly ache once in a while, or a headache. And the first thing you think is, oh my God, it's cancer. So I always tell women, everyone's going to get symptoms as you get older. Give everything a few weeks. If your symptoms are persisting and don't have a good cause, you didn't bang your head, you didn't have a cold, tell your family doctor, get an x-ray or a test. And if anything it shows, of course, we're here for people. We can help control cancer for years often, as you know, even when it is stage 4. But getting back to your question, how do we handle that anxiety? We've known for many randomized trials in England, Canada, America, if half the patients get regular follow-up with their family doctor or with the oncologist, the outcome's exactly the same. It doesn't require a specialist. Also, women think, well, when they finish their tamoxifen or their AI for 5 or 7 years, they're frightened to stop. We know it has a carryover benefit. When you stop, it kind of keeps on working. It's done enough work to turn off those cells so they won't come back later, that giving more is not necessary. Because patients often feel they're cut off and they're frightened. But that's not required. And they often ask too, how do I do, do I need to do body scans to check my body, CAT scans, bone scans? And that we know for sure we don't need to do. 3 reasons. We tried that in the 80s. People had scans twice a year, and the cancer did not come back usually on the scan dates. It came back whenever it wanted to in between. So it didn't work very well. Number 2, finding it a bit early, it still wasn't curable. It doesn't change the outcome. And number 3, every CAT scan has a radiation of 400 chest x-rays. So doing them for fun, on a regular basis is dangerous. So, it's important that we use the test in the correct way. So having an awareness of your body, if something is unexplained and persistent, do check it out. But, don't be fearful and just be, cautious. That's the best we can do. That shadow over life does fade as time goes by. Because after 5 or 6 years, that becomes a trickle of risk, and people tend to move beyond it. Humans are very good at coping once we get over the hump.
So there's no idea of entertaining the thought of putting people back on maintenance, like tamoxifen or AI.
No, we tried that, right? So, we know 10 years is better than 5 for young women. If we give an AI, 7 seems to be magic. If we give 10, it's no better. Because really, we're trying to help the body kill any cells or really put them to sleep. So we're not just trying to control, we're trying to help kill. And that does not have to go on forever. Just like penicillin doesn't go on forever after pneumonia. It's a set time, it does its job, and that's how we view these medications.
Great. And what will be the difference in the outcomes of patients under this whole, new way of treating patients versus the ones that were treated many, many years ago? Do you understand that there is a huge difference? Like where's the research community in this?
The research has been going on actively nonstop since the 70s. It's accelerating. It's much wiser now. Now we don't just find a plant from a plant in Brazil and crush it up and give it to people. We have a lot of preclinical evidence. We have data from stage 4 to say there's a signal this could be promising, and we do randomized controlled trials. And the data is evolving very quickly right now. I think the chance of death from breast cancer has plummeted in the last 20 years, and most of that has not been from better mammograms and picking it up. Most of it has been from better preventive medication. So I think they have been improving things. Once we get to a really good point, we backtrack and say, can we give a bit less? Can we have less side effects? That's what we're doing with HER2 as we're constantly learning. So I encourage all women, wherever eligible, where there's something new, take part in the clinical trials, state of the art, and you're protected, you're given the newest therapies. That's how we learn.
Great. So I'm going to go to questions. And one question here is, Dr. Sehdev, you mentioned that the suggested duration for aromatase inhibitors is 5 to 7 years. What is the suggested duration of CD4/6 inhibitors? Is there any benefit to taking them indefinitely?
No, definitely not. So for metastatic disease, we take them as long as they work. They don't work forever. For the preventive therapies, for abemaciclib, it's 2 years. For ribociclib, we don't have the final proof yet for ribo, but the study was for 3 years. So we'll always be looking at that, over time. But there'd be no logic in taking it longer. Number one, it wouldn't be paid for longer. We only get funding for what's proven to work. They all do have side effects. We don't know if they're safe to take indefinitely, and they're probably not required. If it's done its job well, you can see with the abemaciclib data, after they finished the 2 years, the curves kept getting wider apart. So we call it a carryover benefit. It did not enough of a good job that the separation and how much better people did kept getting better and better after. So we probably don't need to.
If someone has had bad side effects from the AIs, tamoxifen, what other options do they have to address recurrence?
Well, usually, their oncologist will be specifying what those options are. For the anti-estrogen ones, all the chemo, all the high-tech stuff is up front. In the longer term, there's all these anti-estrogens. There are 3 AIs, and there's tamoxifen. It's pretty rare we cannot find one that fits a patient. So we sometimes go through all 3 AIs and find the last one, like exemestane, is the charm, and people don't get the side effects they had before. With the tamoxifen, if that's the last one that seems to be the best tolerated, giving it every second day is a compromise. We didn't talk about DCIS, that's the pre-cancer called stage 0. We have studies there that a quarter dose seems to work almost as well as with our standard dose. We don't have proof of that yet for full-blown breast cancer, but there's a suggestion that if we have to cut the dose for side effects, it probably is okay. So, we're looking at all these different ways to custom tailor. The problem is patients get fed up. And after 4 or 5 visits and trying one, trying the other, they give up. And that's why I tell patients, don't throw the baby out with the bathwater. Let us find the right way for you. Let us help you be on your team. And usually we can get there together. The other options they can do are simply the very important lifestyle thing we didn't talk about. Alcohol is a factor in breast cancer and recurrence. Exercise can lower the chance of getting breast cancer and lower the chance of it coming back again. We don't really know how. So all those important things, smoking, all those things are things women can do for themselves.
Okay. And speaking of exercise, it's very interesting to me how we know we all understand that there is a benefit, but we don't know why. And after all these years, it just amazes me that we still don't know why.
You know,
Is
a
it
woman,
pleasure?
yeah. A woman said, well, there was some theory about a pathway called the insulin growth factor pathway that gets turned off or on by exercise. But a woman today told me, Doc, it's almost like you're telling me what my mom told me growing up. Don't smoke, don't eat, less red meat, exercise more, because they prevent, diabetes, heart, Alzheimer's, cholesterol, high blood pressure, colon cancer. So that is what our moms told us to do, and we're all too busy to do it. I think that's the way it's nature telling us that's how we were evolved and how we're supposed to live.
Yeah, but nature also makes us complacent, and we don't do something unless it's like, oh, red alert, do this because of this. So we kind of need to be led, right, with concrete evidence of things, and otherwise people are like, well, maybe it'll work, maybe it doesn't. So
Yeah,
I
so I
would
think telling a patient that it's not just motherhood comments; these are scientifically shown data that these things make a difference. That helps a lot to motivate people.
Yeah, I would imagine it does. So one question from the audience. She writes, I was supposed to take tamoxifen for 10 years, but stopped after 5 because of depression. It's now been 5 years since I stopped. Should I finish the last 5 years of the 10 I was supposed to do? I guess she's asking if she
Yeah.
just restarted.
Yeah, so you probably have to talk with her own doctor based upon her own risk profile. So I can't comment on the individual case. Of course, legally, we're not allowed to comment on individual cases unless you're my patient. But on the other hand, if it's been 10 years, you're probably cured, because most of the recurrences would have happened by now. So you probably don't need it at this point. Time has already told you that you're kind of over that hump.
Okay. And there's a question about the calcification. What screening is recommended after those are detected on mammogram?
Microcalcifications are chalky dust-like patterns found in the breast, and they can be normal with aging, but the pattern of them can be correlated with different diseases. So a certain pattern can say this might be DCIS, it needs to be cut out, or looks like cancer. So the radiologist, when they report each mammogram, they will specify at the bottom what needs to be done. So depending on the pattern, they'll say do it again in 6 months. It changed a bit, or this needs to be biopsied. So it really depends on what the radiologist has said.
And we have a question about HER2 low, and that's the
Right.
new thing right now. Can you be a little bit specific on treatments for HER2 low?
So I just touched upon that newer drug called trastuzumab deruxtecan. So it's like the TDM1 is trastuzumab, the Y, with the chemo riding piggyback. And just like the sacituzumab govitecan in triple negative breast cancer, the idea is that in HER2 low, there is HER2 on the cell, but it's not amplified. It's not tons of it. So it's there, but it's not what makes the cancer tick. So it's not that we're trying to turn it off to help the cancer, but the fact that it's there means you can use it as a door. The trastuzumab deruxtecan can attach to it. The cancer cell eats the drug in, and the chemo can go there. So we can use the presence of HER2 as a door for these extra drugs to get in. Right now, it's mostly relevant for stage 4. If you have any HER2 on your cell and you've been through all the good treatments, that drug has been found to offer really dramatic benefits. But we don't have evidence yet in the early disease setting. It's being studied in HER2 positive, because it's very effective in HER2 positive patients. It's being studied as TDM1. Someone has chemo, Herceptin, they take out the cancer. If they have leftover, they switch over to TDM1 for the rest of the year. There are trials where we're switching instead to this new one called TDXD. It probably will be better. It's very promising. It has more potential side effects. It does cause hair loss, the other doesn't. It can cause vomiting, the other doesn't. And rarely, about 12-15% can get lung damage that can be life-threatening. So it's something we're still trying to see, where does it fit? But HER2 low is not yet there for early breast cancer.
Next question. Can a complete response from neoadjuvant chemo for stage 3 ER-positive cancer mean a low risk of recurrence?
Yes, a complete response in every kind of breast cancer tells you the cancer was really hit hard by chemo. So whatever cells might be hiding in the body are probably equally well hit, and their prognosis is even better. Now, what's nice in the ER-positive patients is you can make it better by even still giving the anti-estrogens afterwards. So it is a very good sign.
Well, that's good.
It doesn't replace the need for the hormone therapy, though. It's still very important.
Okay. So we have a question here on Dr. Sehdev. Can you speak more on Ki-67 being used as an indicator for tumor proliferation, especially for TNBC?
Yeah, so Ki-67 is a test that roughly tells you how many cells are proliferating. I call it a speed test to make it more understandable for patients. The problem with it is the methods of testing vary from lab to lab. So there's been a lot of issues with the consistency between labs and interpretation. So right now for triple negative, it's not usually very helpful. Triple negatives almost always have a high Ki-67. We know it's kind of a bad apple already by the fact that it's triple negative. There are some rare kinds of triple negative that are not in this discussion. Adenoid cystics, and other cancers that are actually very, very good, have a very good biology that don't express ER, PR, HER2. But those are different. But for the garden variety breast cancer, the triple negative, they are bad enough to need the standard treatments, where Ki-67 is not that helpful. Ki-67 is part of the oncotype testing. So for ER-positive patients where you really have a mishmash and chemo is probably not that important for many of them, there it can be more helpful. And Ki-67 doesn't help tell who needs abemaciclib and who doesn't, for the additional 2 years or the CDK inhibitors. But if it's high, you get a bigger value, a bigger benefit from abemaciclib. And if it's lower, the benefit is there, but a bit smaller.
Thank you. So someone is asking around this question. I have a question. It's around PET scans, and if they're not part of for locations where PET scans aren't not part of the regular follow-up, how should the patient be treated? Can you review very briefly?
Yeah.
Is it now standard of care for PET scan after stage 3, or where are we that? Can you remind
it's not really part of the monitoring, it's part of the staging. So at the very beginning, because stage 3 has a higher risk of it coming back in the body, it's routinely offered in Ontario. I don't think it is in every province yet. and it's only been available in Ontario for about 6 months or so. It's
Oh,
about a $2,000 scan. It does have false positives as well. So in stage 3, it can pick up hidden seeds of cancer in the body, sometimes in a third of patients. And if we know that, we can customize the treatment better. Why go on super intensive, strong curative therapy if it's not curable? You can go on gentler therapies one at a time with the aim of long-term control, but not necessarily going at it whole hog. So less side effects and a better long-term strategy. We don't know yet how valuable it is for earlier stages of breast cancer because it is so sensitive. It picks up more junk, inflammation, old TB, scars of previous infections. So it has to be used with proper caution.
and I would add to that, the delivery of the results is very important because the anxiety that comes with a PET scan that shows, I mean, a PET scan can pick up so much. I would
Nowadays,
say
most people have online charts they can review the results themselves. And I love patients to have the results, but I ask them to wait until we talk about them
that-
because a lot of lingo. One lady was in tears because she saw her mammogram saying normal, no, I think it showed scattered fibroglandular tissue, which means normal. But she thought she had a fibroadenoma, which is not cancer, and she thought it was cancer. So she was in tears. So, it's very important to let the docs explain it, and then by all means, have a copy.
that's a whole topic in itself. Giving the patients that amount of information that is very often not understood properly, and it's anxiety provoking. So I want to go back to stage 0. Now, stage 0 in and of itself is not just like a clean bill of health, like you're going to be okay. Is it not the biology of the tumor that is found?
Yeah, so I'm not an expert in stage 0. In Ottawa, we don't see those patients. They're seen by the radiation oncologists.
Ah.
It's they're even considering when you're older, it's not even worth diagnosing it. It's like men with prostate cancer when it's trivial, you cause more harm by biopsying and poking, and there are more deaths from testing than from the cancer. So stage 0 is considered a precancer. In plain English, it's in the duct but not into the breast meat. And that kind cannot travel, it cannot kill people. So it needs to be cut out because a substantial number of them later would turn into real breast cancer. But they're removed and radiation is given so it doesn't come back in the breast later. Some women may choose to take tamoxifen more to prevent getting a future breast cancer, not to treat that one. So it's a bit of a different ball of wax.
Right. We're really coming close to our time. Bakun, can I ask one more question or no? Dr.
Yeah, go ahead.
Okay. So how is TNBC detected by a pathologist? So
it's a kitchen sink. Basically, it's detected by not finding the 3 things. So if there's no estrogen receptor, no progesterone receptor, and no HER2, if HER2 is not revved up, then it's called TNBC. It's the absence of 3 things. So that's the designation. And there are probably at least 5 major subtypes of TNBC that we're learning now maybe how to treat them differently.
And in conclusion, what are your last what do you project in the next little while that is going to be exciting?
If we look at the curves, we're going to get better and better at curing more and more patients with better preventive therapies, but we're getting into a slippery slope where for every extra percent cure, we're going to have a bit more side effects and a tremendous more financial cost. So there'll be that kind of devil's trade-off where we'll have to really decide with the governments and with patients at what point is that extra treatment worth it. I think we're also getting better at prevention, better at screening. We didn't talk about that today, but if women have dense breasts, by doing MRIs with mammograms, we'll pick things up even earlier and have even better cure rates.
Thank you. So that leads me to the closing remarks. Of course, this concludes our time for today's session. Thank you, everyone, for your questions. And I'm sorry that not all the questions were, answered, and for joining us to learn about these recent advancements in treatments. and care and research for early stage breast cancer. I want to thank Dr. Sehdev again for being here with us today. And I wish to thank again our sponsors, Novartis, AstraZeneca, Gilead, Seagen, Merck, and Roche. Following this session, you will get a link to complete a survey to provide feedback on the session. Please consider leaving feedback, as this very much helps us improve future sessions for attendees like yourself. Our next virtual education session will be on Tuesday, September 12th at 5 p.m. In that session, a general practitioner in oncology will spend the entire session answering your questions about post-treatment and survivorship care. So we look forward to connecting with you all then, and I wish you all a lovely evening, and thank you, everyone.